Thank you. Welcome to this spotlight session this afternoon, where we'll be publicly launching the refreshed ranking of research priorities for palliative and end-of-life care. My name is Erica Borgstrom, and I'm a professor of medical anthropology at the Open University. I'm delighted to be chairing today's spotlight session, where we'll be sharing these new priorities, as well as exploring data from the project specific to mental health and well-being. My colleague John McCartney will also be presenting on our research where we carried out a secondary analysis of the data from the project to identify palliative and end-of-life care research areas for the social sciences and humanities. At the end of the session, we're going to aim to have 10 minutes to take audience questions. Please type your questions in the presentation chat throughout the session. You can find this chat either by clicking the message icon on the blue panel. This should either be at the right-hand side of your screen, or depending on how you have your window open, it may be at the bottom. We have some colleagues that will also be filtering bits from your chat into the Q&A so we can pick these up later. This session is being recorded and will be available on demand on the conference platform after it's done. I'm now going to hand over to my colleagues Bryony Hudson, the Associate Director for Internal Research Development, and Dr. Sabine Best, the Associate Director, Research Management and Impact. They're both from Marie Curie and are presenting the new research priorities for palliative and end-of-life care. Over to you both.
Thank you, Erica, and good afternoon, everyone. So I'm going to make a start, and Brian is taking the second half of the talk. So I'm delighted today to introduce to you the research priorities for palliative and end-of-life care that were identified and prioritized by people with lived and/or professional experience. And this was done through a refresh priority setting partnership in collaboration with the James Lind Alliance, with co-funding from the Economic and Social Research Council as part of UK Research Innovation, so that's the ESRC, and the Motor Neuron Disease Association. So why is this important? The recent estimates suggest that around 90% of people who die in the UK need or could benefit from palliative care, but we know that not everyone that needs palliative care receives it. And we know that access to palliative care is highly inequitable, with factors such as diagnosis, socioeconomic status, and ethnicity influencing who gets care and how. We also know that, for instance, in 2022, only 0.23% of the 2.8 billion of health-related non-commercial research funding in the UK was assigned to palliative and end-of-life care research. So as a sector, we have very limited funds to work with, and therefore it is crucial that the research that is funded is aligned with and informed by what is important to people with lived experience. And the James Lind Alliance offers a route to achieving that. And the priorities sorry about that. The priorities that we will share with you today represent a refresh of a priority setting partnership that reported back in 2015. On the slide, you can see the top 11 priorities that were identified in 2015, and these may be familiar to some of you. I won't read them all out, but you can see here that the top priority in 2015 was providing care outside of working hours. Other issues within these priorities included working towards equity and access to care, explorations of advanced care planning, information and support for families and staff, and the identification of palliative care needs, to name just a few. And for researchers and research funders alike, these priorities provided useful insights into what people with lived experience felt was important for research to address. And before we embarked on the refresh that we will discuss today, we've reflected on these priorities and the extent to which these issues may have been addressed through research since 2015 already. And to help us think about this, in 2023, we published a ground mapping report. And the aim of this work was to give an overview of research funding in this field between 2015 and 2022, and explore the extent to which this could be mapped against the top 11 priorities identified in the 2015 PSP. And this analysis was based on data from the UK CRC Health Research Classification System for 2022. It's a really interesting report for research funders, and on data collected directly from research funders themselves. And from this review, we saw that each of the top 11 2015 priorities had received some research funding since their publication in 2015. And there was, however, a great variation in the amount of funding allocated to different priorities. In priority 3, for instance, regarding the benefits of advanced care planning, received the most direct funding, totaling almost £8 million across 31 grants. And in contrast, priority 11, how to support people who live alone or are socially isolated, was at the other end of the scale and received the smallest amount of funding. Only one grant was awarded on this topic, coming in at around 800,000. And remembering the grant, the question was not even the sole focus of that particular grant. So the chart shows the number of palliative and end-of-life care research grants that were awarded in this period and who they were funded by. And you can see that the NIHR and Marie Curie funded the most palliative and end-of-life care research project in this time frame, each funding 42 different studies directly linked to the top 11 priorities. And that's not surprising. NIHR is the largest funder in this area in the UK. Marie Curie is the second largest funder. So I do have to note that the grants from the NIHR, as you can imagine, tended to be larger than those from Marie Curie. And the ESRC was identified as the third largest funder, mainly because of the £4 million Embed Care research grant, which was jointly funded by the ESRC and NIHR. This was a grant around needs for people with dementia. And but also important outcomes from the 2015 PSP were successful funding partnerships. For instance, we jointly funded research calls between Marie Curie and the Motor Neuron Disease Association, and you can see 3 grants there for the MND Association were co-funded by Marie Curie, and also joint funding with the Chief Scientist Office in Scotland, which resulted in a number of studies addressing Scottish research needs. So we established that each of the top 11 priorities had received at least some funding since their identification. And the next step in our preparatory work was to explore whether any of these priorities had been fully addressed through research since 2015. And to help us begin to answer this question, we worked with an information scientist aligned with the James Linder Lines. And in August 23, they completed an evidence check relating to each of the 83 questions identified in the 2015 project to see whether any were fully addressed by research. So quite a big enterprise. And this involved searching PubMed using the terms palliative care, bereavement, and systematic review to find reviews published between 2015 and 2023, which aligned with any of the 83 questions identified in the PSP. And that's the standard methodology that the James Linder Lines uses to identify whether a question has already been asked, whether a question has already been answered. So this was clearly not a comprehensive search, but gave us an indication of the amount of evidence relating to each questions. And the information scientist then extracted the conclusions of each study and considered them according to the priority to which they could be mapped, and made an assessment of whether the questions had been answered, partially answered, or not answered at all. And you can see this in the table there. A green rating would indicate that the question had been answered, so there isn't any. Yellow indicates a partial answer, so there's some evidence that has been created, that has been put together since 2015. And red would indicate that the question remains unanswered. And the table shows the numbers of reviews as well and ratings for the top 11 priorities from 2015. From the top 11, there were 4 questions that had been partially addressed by research, and these related to the benefits of advanced care planning. So there was a lot of investment in that area, so that makes sense. Information and training that carers and families need, the best ways to determine palliative care needs for patients with non-cancer conditions, and identification of the core palliative care services. And do remember those 4, as we will come back to some of them later. So overall, of the 83 questions, 20 had been partially answered, and that's all in the report as well. So, of course, these findings could be for a number of reasons, and it might be related to the evidence check itself. As we said, it's quite, it was very broad, not very thorough, but also it might relate to the questions themselves, because they tend to be very broad, and that's so it's not surprising that they haven't been answered completely in the last 10 years. But so there was time for a refresh. So after reflecting on all the work that's been done across the sector, involving many people maybe some people in this audience. Since the first priorities were set, we felt that the time was right to once again ask people affected by serious life-limiting illness what they felt future research should focus on. And we were keen to collaborate on this work again, and to ensure that we had representation from a range of sectors and funders, all of whom have a role to play in palliative and end-of-life care research. And we were supported by the James Linder Lines, with co-funding from the M&D Association, who also supported us in 2015, and the ESRC likewise. But there were some changes, so some important distinctions between the PSP and the 2015 PSP was the establishment, for instance, of a lived experience group to support and guide this work. And this time around, we also collected a bigger range of demographic information from respondents. And we did this at the time in 2015. We didn't ask very much in this area because we didn't want to increase the length of the survey. With hindsight, it's always you always know better, and for this we learned from this. So we wanted to understand the voices that we heard, but importantly also the voices that we did not hear within the surveys and the workshops. And so today we present the refreshed priorities for palliative and end-of-life care research on behalf of the Lived Experience Group, on behalf of the steering group and our co-funders and participants. And with that, I pass on to my colleague, Bryony.
Thank you, Sabine. So before we reveal the top 10 and indeed the top 24 priorities, we'll just give you a quick overview of how we got here. So we followed the process that was set out in the James Linder Alliance handbook. And the first stage of this is to bring together a steering group, and we added a lived experience group to together agree on the scope of the PSP. And for this project, the scope was to identify and prioritise unanswered questions from people living with serious illness, those close to them, and health and social care professionals involved in their care. And the first step of the project was to create a survey, and we created this online. And the aim of this survey was to ask people based on their experience, what problems or needs should future research address to improve the experience of people with a serious life-limiting illness and those close to them. And we worked with our lived experience group and our steering group to try and make this survey as accessible as possible in terms of the wording, the format, and where and how it was shared. And in total, we had over 1,000 responses to the survey, which we're really pleased about. So once we had collected these responses, our information scientist reviewed these, and she categorized these into a list of questions. And we formed a data subgroup, which consisted of members of the steering group and the lived experience group. And together we met on many occasions to discuss, review, and refine the questions that the information scientist had put together. And at the end of that process, we had a list of 79 questions. The information scientist then repeated the evidence check for all of these 79 questions, and we established that none of them had been addressed thoroughly by research to date. So they went forward to our second survey, which was a prioritization survey. And it asked people affected by serious life-limiting illness, either in a personal or professional capacity, to tell us how important they felt each of those 79 issues were to be addressed by future research. So we had about 600 responses to that survey, which is brilliant. And we looked at that data in a number of ways. We looked at the ratings and the rankings of those 79 questions across the whole sample. We looked at the ratings of people with professional experience and those with lived experience. And we took the top 20 from the people with lived experience and professional experience through to the priority setting workshop. And there was quite a lot of overlap between these groups, and taking the top 20 of each led us with 24 questions to take forward to that priority setting workshop. And this is where they were discussed and ranked, and we came up with a list of top 10 and a list of 24. So these are they. Here are the priorities for palliative and end-of-life care research that were identified through this PSP. I'll just take you through them now. So number 1 was, how do people with dementia experience end of life? How can palliative and end-of-life care better meet their needs and those of their carers, friends and families? Number 2, how can NHS social services and charities work more collaboratively to provide joined-up care that better meets the needs of people with a serious life-limiting illness, their carers, friends and families? And number 3, what kinds of palliative and end-of-life care support need to be in place to enable people to die well at home? What skills do staff need, and what helps or hinders the delivery of care at home? Number 4, what are the best ways to provide personalised palliative and end-of-life care that meets all of the physical, mental, practical, social and spiritual needs of a person with a serious life-limiting illness? Number 5, how can palliative and end-of-life care better meet the complex needs of people with multiple health conditions? Number 6, how can communication and care coordination be improved across the teams of health and social care professionals caring for people with any serious life-limiting illness? Number 7, what skills, training and information do carers, friends and family members need to be able to care for someone who's dying at home, e.g. by giving medicine safely by injection, managing incontinence or moving people? And what are the pros and cons of upskilling the people giving care? Number 8, how can the quality of palliative and end-of-life care in hospital be improved, and what helps or hinders improvement? And number 9, what are the best ways to provide palliative and end-of-life care support and advice at all hours? 10, how can palliative and end-of-life care better meet the needs of people who live alone or are socially isolated? So there you have it. There's the top 10. But what our steering group and our lived experience group felt was really important was that we emphasised the rest of those priorities and not just that top 10. So from the prioritisation survey, there were 24 issues that were identified as the most important by those two different groups that I mentioned. And I won't read out the top 24 today, but just to highlight a few issues that came up within that top 24. And those were issues of training and support for staff, providing emotional support to both patients and carers, meeting the needs of people with illnesses other than cancer, and finding the best ways to identify that a person is near death. And here is the last ones, and I'd encourage you to have a look at the full report, to have a look at these in more detail. But just to pick a few from here, things about symptom management, thinking about things that stop people's wishes from being acted upon, and managing pain at the end of life were other issues that were identified as important. So these priorities were set back in November, and since then we've been thinking about some of the similarities and differences between those that were set in 2015 and those established a decade later. And on the left of the slide, we can see the priorities that appear in the top 10 of both the 2015 and 2025 priorities. So out of hours care was the highest priority in 2015, and it was also in the top 10 in 2025 at number 9. In the current PSP, dementia, supporting people living with dementia, was number 1 priority, and this was represented in 3 separate priorities back in 2015. So other issues that appear in both the top 10s are care at home, coordination of care, and supporting people who are socially isolated. But on the right, we can see some of the issues that appear in the top 10 in 2015, but were outside of the top 10 in 2025, although they still appear in that long list. What we thought was quite interesting that there was variation in how the priority was expressed or emphasised in some cases. For example, the best ways and benefits of advanced care planning was identified as priority 3 in 2015, but in 2025, the question about advanced care planning had shifted to what stops people's wishes being acted upon, rather than how should these conversations take place. And in recognition of the need to consider priorities falling outside of the top 10, this table shows some of the issues that appeared in the long list of both PSPs. And we can see notable differences in these rankings across the decade. For example, issue number 2 in 2025 concerned how NHS, social services and charities can work better together. And in 2015, how to best facilitate communication across services was ranked at number 13, perhaps reflecting a need that's becoming more pressing. And care in hospital moved up the priority list from number 16 in 2015 to number 8 in 2025. And indeed, how to support discharge from hospital was a new entry into the 2025 list, reflecting recent research about experiences and also costs in the last year of life. And finally, in addition to hospital discharge, other priorities that appear in 2055 that were not present in 2015 include how best to provide personalised care and how to support people with multiple and complex health conditions. And each of these new additions are likely a reflection of a system pressures that we're facing at the moment, and a call to action to consider how we support a population that's ageing and whose care needs are becoming more complex. So thank you very much for listening to this overview of the priorities and how we arrived at them. But really, this identification is just the beginning. So at Marie Curie, we're committing to using these priorities to inform our next Open Grants call, which will open later in the year. And we hope that other research funders will also be inspired by these priorities to help widen the impact that they can have. I'm sure you've noticed that these priorities are not a set of research questions, but they represent areas for us as researchers and research funders to consider. And collaboration will be essential to build the multidisciplinary projects that we need to address these issues. And to support this, we've made the anonymised data set from Survey 1 and all of the evidence checks available online. And we'd encourage other researchers to explore these and consider possibilities for secondary analysis and further engagement. And indeed, this afternoon, we're delighted that we'll be hearing from 2 projects that have already done that. And I won't say any more about those, as you'll hear about them shortly. So all that remains for me to say is a very big thank you. Thank you for listening today and engaging with these priorities. And thank you to our funders and our supporting organisations, our steering group and our lived experience group. And thank you to everybody that shared their time, views and experience to help us develop these new lists of priorities.
Thank you both. And also, indeed, thank you to everyone that was behind that big project. It's quite an endeavour to collect all that data, sift it and make sense of it, and let alone prioritise it. And I have first-hand experience as a researcher who has used the previous list to help design a study, and it's a really valuable asset to help us think about the type of work that we're going to do. I also want to thank all the people that are currently watching live and those that are going to catch up on the recording. For those of you who are joining us live, please remember you can add your questions and or comments and reflections to the chat box. You should be able to see this either in the blue ribbon that could be at the right-hand side of your screen or depending on how you have the window open at the bottom. Charlotte's also put a note in there about where you can find the report, and you'll see these also in the virtual booth that's in this conference platform dedicated to the Spotlight session. I'm now going to hand over to Dr. Anne Finucane, who's a Senior Research Fellow at the University of Edinburgh and is also linked with Mary Curie. She'll be presenting the findings from the project that's specifically focused on mental health and well-being, which you saw a brief image of in Bryony's last slide there. Over to you now, Anne.
Thanks very much, Erica. Let's see. Let me see, can you see my slides?
We can see that, and just go into present
From
slideshow.
Sorry. You can see, let me see.
We can see everything at the moment, so if you just, oh, you might have got it. Yeah, that's great.
Okay, just one moment. You can, oh, is that, you can still see, just one moment now until I, okay, I'm just trying to get the presenter mode. Do you know how I do that? Sorry, just one moment until I try and get,
I think it's top right.
oh, sorry.
Can you see your notes, Anne? Because we can see the slides just fine. So if you just get your notes up,
Okay.
then all we can see is the slides, so don't worry about putting them over.
Okay, I might just open that separately. Just apologies. Just just one moment. I'm nearly there. Okay. Is that moving forward for you guys? Is that, can you see that okay? Okay.
It's not moving forward, Anne.
Is
what
that
I
moving
can
now?
do, if you want, I can share the slides, and then you can just follow your notes if you want, and just say next slide if that's easier.
Okay, fine.
Is that
Can you
easier
do that?
for you?
Yeah.
Yep.
Yeah, apologies.
Just give me one moment. And
So thank you both. And for those of you, while we're all waiting for the slides to come up, this is a great opportunity for you to add things into the chat box. Charlotte's asked where you're from and who you are, and also like if you have any questions or reflections on the first presentation, you can add them there. All right, it looks like the slides are ready. So over to you, Anne.
Okay, sorry about that. So thank you very much. And I'm delighted to be here to present our findings on mental health and wellbeing research priorities in palliative and end-of-life care. So just next slide, please. So I'd like to acknowledge the wider team, including co-lead Bryony Hudson and both Nick Willey and Charlotte Simpson-Green, who are very much involved in data analysis. We're also very grateful to Marie Curie for funding this work. So next slide, please. So mental health is, so first let's look at a definition of mental health. So according to the World Health Organization, mental health is a state of mental well-being that enables people to cope with the stresses of life, realize their abilities, learn well and work well, and contribute to their community. However, for people diagnosed with a serious life-limiting illness, there are significant challenges to maintaining mental health and well-being, and opportunities to learn, work, and contribute to the community. Activities a person may previously have found purposeful and meaningful become increasingly limited. In addition, uncertainty regarding the future means that the individual and their family is in uncharted territory, where usual ways of coping and problem solving may no longer be effective. Despite this, mental health and well-being for people impacted by life-limiting illness is often overlooked. Next slide, please. National policy documents such as the Mental Health and Wellbeing Strategy for Scotland focus on delivering mental health care in the early years, including from preconception. This is important. However, in this model, there is little recognition of the mental health and well-being needs of people diagnosed with a life-limiting illness and people approaching the end of life. Across the UK, over 600,000 people die from an advanced illness each year, and over 3 million people are bereaved. Greater recognition of the mental well-being experiences and needs of this group is required so that appropriate support is commissioned and delivered. Next slide, please. So why focus on mental well-being? Well, we know that palliative care is holistic in nature, and addressing psychological, social, and spiritual domains are essential aspects of good quality palliative care in any setting. Distress is commonly experienced by people with a life-limiting illness, and around 60% report emotional concerns. Staff caring for people with an advanced progressive illness regularly encounter psychological distress in their everyday work and need to know how to respond and best support families. Critically, unaddressed emotional distress may hinder engagement with health services, limit future care planning and opportunities to live well and create legacy. And poor mental well-being, in particular depression and hopelessness, may lead to a desire for a hastened death. Despite this, research on mental health and well-being towards the end of life is fragmented and lacks visibility. In terms of progressing research in this field and informing future clinical practice and service innovation, there is a need to identify what evidence is most needed. Next slide, please. So as outlined by Bryony and Sabine, the James Lind Alliance Palliative and End-of-Life Care Priority Setting Partnership refresh was conducted last year. This resulted in survey responses from over 1,000 healthcare professionals and members of the public regarding what future research should focus on. So our team thought that there would be value in analysing these responses to look specifically for evidence needs relating to mental well-being and advanced illness. This in turn could guide future decisions around priorities for mental well-being research and research funding. Next slide. So here I present an overview of our methods. In terms of data sources, we drew on data from the JLA, Palliative and End-of-Life Care Priority Setting Partnership, which consisted of over 1,000 survey responses. We also drew on data from a webinar on mental health and wellbeing research priorities that was undertaken last year as part of our Mental Health and Wellbeing in Advanced Illness Network. You can click ahead there, there's some images that will appear. Thank you. Data from both datasets then was imported into NVivo and coded for themes and subthemes relating to mental well-being. You can click on the next one, please. This resulted in a thematic map consisting of 12 areas for research, which were subsequently discussed at 4 focus groups involving 29 participants. Click once more, please. Focus group data was also imported into NVivo and used to refine and elaborate on the original thematic map. This process resulted in a set of 10 broad priority areas for mental health and wellbeing research for people with serious life-limiting illness, which I will now share. So next slide to see the first theme, and these are in no particular order. So the first area is living well. What are the best ways to support people to live well with serious life-limiting illness? Participants were interested in research on factors that predict coping and adjusting well to illness. They wanted research on the strategies people can use to maintain a good quality of life despite illness. The focus here being on living well as opposed to managing problems. And And there was also an interest in the value of acceptance-based interventions to help people adjust. On the right, you can see a quote from one of the respondents who was interested in research on positive predictors of coping. How are people managing so well? What predicts people's abilities to adjust and maintain their well-being? Next slide, please. Communication was another key theme. Respondents and participants wanted more research on the best ways to enable open, timely, and sensitive conversations around living with serious life-limiting illness. What are the best ways to promote open and sensitive conversations between families and healthcare professionals? And what can we learn from research about supporting people to initiate these conversations with each other? What can we learn from psychology and related disciplines about acknowledging uncomfortable and distressing issues when such acknowledgement is needed to plan ahead and make the most of the time a family has together? So, for example, a respondent via a member of the public who completed the JLA survey was interested in training for staff in general hospitals about palliative care, and talking to patients about what they want would be a high on my list of priorities. Next slide, please. Our next theme is around managing anxiety and psychological distress. Specifically, what are the best ways to prevent and treat anxiety and psychological distress for people with a serious life-limiting illness? Participants and respondents wanted research on the best ways to assess psychological support needs, approaches to effectively manage anxiety and distress, and ways to improve access to information to help manage expectations and uncertainty. For example, one respondent asked for research on psychological support to better manage acceptance of end of life or to overcome the anxiety around dying. There was also a desire for more research on needs of people with pre-existing mental health problems and severe mental illness. What are the particular needs of this group, and what are the best ways to coordinate care across psychiatry, psychology, and palliative care for these individuals? Next slide, please. Social connection was another key area identified for research, with participants expressing an interest in research on the best ways to support people with a serious life-limiting illness to remain connected to each other. There was a desire for research focused on the ways to alleviate loneliness, especially given the increasing numbers of people living alone. There was also a desire for research on how to support relationships between people as health declines. For example, the quote here from a bereaved family member asks about supporting people in their relationships. Some respondents highlighted a need for research on the role of the community in promoting friendship and peer support for people with advanced illness and those caring for them. Next slide, please. The next theme is focused on spiritual care and the best ways to provide spiritual support to people with a life-limiting illness. The quote here is from a healthcare professional who asks for more research on how to ensure good spiritual care from clinicians and spiritual care experts can be provided at home or in inpatient settings for all who would value it. Respondents also wanted research on spiritual care in all settings, including in all settings where palliative care is provided, including care homes. Next slide, please. Unsurprisingly, caregivers were identified as a thematic area for future research, with respondents asking for more research on the best ways to support caregivers with stress, distress, and exhaustion. Respondents also asked for more research on identifying caregivers at risk of complicated grief and on ways to promote adaptive coping. The quote here is from a member of the public, highlighting the need for a listening ear and the importance of psychological and social support to aid decision making. Next slide, please. Respondents wanted more research on the best ways to provide effective, culturally sensitive and timely bereavement support. We know a lot about bereavement support needs, but there is less evidence on how these can be addressed. Respondents and focus group participants wanted more research on effective support that can be accessed when needed. Participants also highlighted the need for research on bereavement support in the very early days of grief, recognizing that current models tend to provide support a few months later, and that those struggling in the early days may have little or no support. Next slide, please. Our final three themes are cross-cutting and all relate in some way to the themes previously described. The first of these is intervention delivery. What are the best ways to deliver and routinely implement mental well-being support? Respondents wanted more research on this, and they also wanted research on assessing mental well-being, examining the benefits and unintended consequences of using digital technology to provide mental well-being support. Next slide, please. Access is another cross-cutting theme. How can it be ensured that everyone with a serious life-limiting illness has access to mental well-being support should they need it? There was a desire for research on developing models of care that widen access to mental well-being information and support, with a particular focus on tailoring approaches for specific groups, including children and young people and people with dementia. Ensuring access to culturally appropriate support was also a key aspect here. Next slide, please. Finally, there was a desire for future research on the workforce, in particular upskilling the workforce in order to provide good mental well-being support. This included developing advanced communication skills and training staff to better assess mental well-being needs and provide appropriate evidence-based mental well-being support as needed. There was also a recognition of the need for research on avoiding staff burnout and attrition. Next slide, please. So there we have our 10 themes describing the broad priority areas for research on mental well-being for people impacted by advanced life-limiting illness. Next slide. When asked, focus group participants found it hard to prioritise specific areas or research questions. However, across all groups, there was a strong consensus that there was a need for more implementation research and greater implementation of research evidence overall. Other key areas were a desire for longitudinal research, examining the patient or caregiver experience over time, research on cost effectiveness and economic evaluation of interventions, and more evidence synthesis to bring current research findings together to inform service development and practice. Next slide. Finally, I'd like to mention our next steps. I briefly mentioned our mental health and wellbeing and advanced illness networks earlier on in this presentation. This is funded by Marie Curie. My colleague David Galanders and I established this network a year ago to promote research and knowledge exchange in relation to mental well-being for people approaching end of life. We now have over 300 members across the UK and further afield. You can find out more about the network on our website, and you can check out our previous webinars in the webinars section. You can sign up or join for free, which means you will be kept up to date of events and research opportunities. In relation to the work described here, our next steps will be to create special interest groups consisting of members interested in working on research funding applications relating to our 10 priority areas. And on the 8th of May, we're holding a grant writing and networking day in Edinburgh. This way, we can start to support collaborations and progress mental wellbeing research in this area. We will be updating the website shortly with further information, so please just keep an eye on it for now or just join up as a member. Last slide, please. So thank you very much for your attention, and please feel free to get in touch with any questions.
Wonderful. Thank you, Anne. And as you so rightly articulated, it's absolutely vital and important that we consider mental health and well-being in palliative and end-of-life care research. And it was really intriguing how you said people found it hard to prioritize, but that implementation was one of the things they really wanted to see going forward. For those of you who've been watching this live, thank you for all the reactions with the emojis, but also if you have any questions for Anne, please pop them in the chat. The chat box is within the blue ribbon, usually on the right-hand side of your screen. I'm next going to hand over to Dr. John McCartney, a Mary Curie Associate Professor based at the University of Warwick and the Mary Curie Hospice, West Midlands. He'll be sharing the insights from a collaborative research project focusing on identifying social science and humanities research areas for palliative and end-of-life care, covered in our latest report called To Know Dying. Over to you, John.
Thank you. And can just confirm you can see my first slide there?
Correct, yeah.
Okay, and that's jumped across to the second slide. Excellent. Right, well, thank you everybody for joining me. And yes, I'm here to talk about our work on the JLA priorities. And I was delighted to be working with Erica, who's chairing the session today, and with Mari Greenfield, and with Bryony, who we heard earlier. And our research, as was previewed earlier, was to use the first survey from the JLA Priority Setting Partnership, and to use that to explore some potential research areas for the social sciences and humanities. And the reason we wanted to do that as for social scientists was that we were influenced by the phrase that Alan Kelleher is sometimes heard to say, that dying is a social and political issue that healthcare is sometimes involved with. And we were left to wonder what would happen if we approach these research priorities with that in mind. And how might that help us think about the research priorities that the JLA that Bryony was talking about earlier, and we can look at those from that social science perspective as well. So I'm going to get into discussing how we've done that. This is as much as the methods I would like to go into at this point. We do have a paper that is the whole protocol is available if you're interested. But we took that initial response to the survey, and we categorized those under 37 broad labels, and you'll see some of those, you'll see all those labels in the following slides. Our main piece of work was to have a collaborative analysis workshop. We brought a number of researchers from across the social science and humanities together to go through the first part of the survey, and we went through a number of activities to go from those responses to identifying 5, as it turned out, research areas for social sciences and humanities. We then went through a period of reflection and working on those to write it up, working with our advisory group, who is a number of people from across the social sciences and humanities. And this was a really interesting process, and as far as we're aware, for the social science and humanities, first time this has ever been done. And I suspect the same for Anne as well, the first time this use of JLA data to think about research areas outside of the core clinical issues. So this is, a really interesting experiment, if you like. And thank you to Marie Curie for funding us to do this. So what did we find? We found 5 interlinked, non-hierarchical research areas, and a lot like an Anne study, where there was a reluctance to prioritize. We also had that because we had a huge range of humanities and social scientists all arguing their corner for what they thought was important. And so to try and have an idea of what was the first one, what's the most important there was not going to work. But what we did find, and what we have identified, are 5 gateways to the social science and humanities. So these are areas that we want to encourage you to be thinking about, as if you're a clinician thinking about research, or if you're a social science and humanities researcher, you'd be thinking about these areas in relation to palliative and end-of-life care and dying. So I'll just go through each in turn, but if you want more detail, that is in the report. So as you can see on each slide, I'll have the initial areas that we identified in the survey data, and then the workshop produced this heading, and then we've got some description about what that might mean for us, and that's across each slide. So in the first research area was experience, practice, and education, and this was to emphasize how the social sciences and humanities can show how experience of delivering or receiving palliative care are connected to multiple layers and multiple levels of the social and cultural context, and use these insights to better inform practice and education. And here there was a real emphasis upon not just the interpersonal and interactional levels of social life, but also thinking about those meso levels of organizations and policy and so forth, but also the macro level, the politics, the society, the culture that we have around us, and how they come to affect those everyday interactions and understandings of dying, palliative care, and end-of-life care. The second research area was awareness, communication, and planning, and again, the same process here. And this is where our workshop panelists wanted to emphasize how the social science and humanities can show how communication about dying is multi-directional and multi-layered, and that this is really important when planning for the end of life, as this involves, really value-laden dynamics about what is possible and what is needed. And this is really emphasizing the multiple aspects of communication, that it's not a simple moment of providing information, that there are cultural norms about what is good communication, how do we know what is good about communication when we see it. The idea that communication should lead to a consensus in the clinical relationship. Where does that come from? How helpful is that in these really complex, very dynamic spaces? So, these sorts of examples were the sort of things that we would gesturing to with the in this theme. The next research area is power, ethics and transitions, and here we're looking at the dynamics of power from the interpersonal to the systemic, and really emphasizing here with this is what social science and humanities spend a lot of time thinking, have spent a lot of time thinking about, just the different ways that power is understood from the interpersonal, again, through the different aspects of different layers of society, and all the various historical aspects to power and how these different things affect the relationships, and having a really strong understanding of how these can be seen in how the dying body is understood, the types of relationships that are valued, and what is what it is to understand dying as we do. The penultimate research area was time, space, and care. And this one was really focusing on the different aspects and the different ways that the dying person might be understood and dying might be understood in relation to what we might call the moment in their dying trajectory or the dying journey, but also where they're being cared for at the end of life. And how these, again, understanding the different values and the different norms that are in place, and the different ways of understanding these particular issues do change when we think about the value of someone's life months from the end of life, or how we particularly verify particular spaces of dying, such as dying at home or dying in hospices, over other places, and how these might affect how we then think about what dying is. And the final area was diversity, equity, and society. And here it was really important to draw upon and to reflect on the long history that humanities and social sciences have had in thinking about these issues, and particularly about the different ways that difference is made to matter symbolically and materially through the different cultural, political, economic systems through which people live and die. And a really important aspect of working with social science and humanities would then be to really unpack these different aspects of difference, of what matters when, and how they come to be understood to be important in different places. And perhaps these sorts of issues have never been more important than they are at the moment. So what do we do with these research areas? How might they be used? Well, like I said, we hope they're a gateway for, a two-way gateway for people to both come to social science and humanities and see what they might offer to think about the research areas they're thinking about going off and investigating, but also for social science and humanities researchers to be thinking about, oh, well, I work in this area. It appears that I might have something to say and contribute to and help with understanding how people are experiencing dying. So one example, we can see how they correlate with the priorities. This is the fifth one of how can palliative and end-of-life care better meet the complex needs of people with multiple health conditions. So we might want, think this through in any one of the 5 ways and all of the 5 research areas that we've identified. But what I would highlight in particular maybe is the diversity, equity, and society one, that assessing what somebody's complex palliative care needs is to point to the points of difference that they have from other people in other groups, and to draw on understandings of not only what their health condition is, but how that health condition is seen to be seen and understood as a type of health condition in relation to other health conditions, and in relation to the person as their demographics and their identity, and how these things are intermeshed in any assessment of what sort of care they might receive and where that care might be placed. And we know that that across palliative care, there are differences in conditions and demographics about who gets what care when. And so social science and humanities are really good at unpacking these sorts of things and giving you the intellectual and conceptual tools to be thinking through these things, but also the methodological tools to go in there and ask the right types of questions in order to start to see how these different issues, these different understandings of difference might be affecting how complex needs of people with multiple health conditions could be better met. So the take-home message then is for social sciences and humanities to be included in more in research and to assist, and they can do this by assisting to help ask better informed questions, which can provide important insights into the social cultural context that affect health and social care practice. And this can contribute to policy development that might be better attuned to provide improvements to support the dying. And like I said, this is a call to all those involved in research, to the funders, to be thinking about the role of social sciences and humanities, where both in the calls that they put out for different types of research into dying and palliative care, but also when assessing individual grants. Is there a social scientist and a humanities scholar on this grant? Does it need it? You know, if you're dealing with any aspect of healthcare, there's going to be a social political aspect to this, there's a context to this. Maybe there's having someone from the social science and humanities might help strengthen that grant and that proposal. And for that, we want researchers both from the clinical spaces and in the social science and humanities spaces to think about working with their colleagues in the others from the other areas in true multidisciplinary style to think through these issues, because we're all looking for the same thing, which is to improve the end-of-life care, to improve understanding and experiences of dying in society. So, you know, if we can use our report, like I say, as a gateway to facilitate those coming together of researchers from different areas and funders to recognise the value of having social science and humanities research on their involved in the grants that they're funding. And you know, there's good evidence to show that having social scientists involved in your research and your clinical research does improve impact and the effects of your grant. Thank you. They're the references, and that's everything for me. If you want to hear more from us, please do follow us on myself and Erica on Blue Sky, or drop us an email. There will be further aspects to this project in due course, and you'll hear about them there. Thank you.
Thanks so much, John. And indeed, all our speakers who I'd like to invite to come back on camera if possible. We now have a short time for questions, which will be drawn from the chat box. If you do have a burning question, please pop it in there soon. But before I turn to that Q&A, just a really quick reminder for everyone watching that there's a conference booth dedicated to this session on the platform here, where you'll be able to find all the reports that have been mentioned today. So if there's something someone said and you think you've missed it, do look at that later. All right, I'm going to move to the Q&A and we'll see here. So I have one directly addressed to you, Anne. So I know you are a middle presenter, so I'm going to skip Brian and Sabine to start with. But Anne, I have a question here wanting to know if you've explored the area of severe mental illness and end-of-life care at all in the work you've been doing.
So I haven't personally been involved in work on severe mental illness, but as part of our network, our mental health and advanced illness network, we are really interested in, you know, bringing together and sharing evidence on a whole range of areas, including severe mental illness. And so we're very fortunate that Dr. Sarah Yardley down at UCL has a particular interest in this area, and she'll be leading one of our webinars in September. So I've put a note in the chat on that, and it's I think I've put the date there. It's the 16th of September. We'll have a lunchtime session which will be specifically focused on mental health and well-being for people with a severe mental illness who are approaching end of life or who have an advanced illness. So everyone's welcome to come along to that, and it's a really important area that we hope to develop for the future.
Wonderful. And thank you already for sharing that information. So I'm sure people can go and follow that up afterwards. I have a question that's going to go across all of our panelists. So we'll take it in turn with Sabine first, then Bryony, then Anne, and then John if possible. And that is what would you like to see those listening to the Spotlight session do after the session?
Wow, that's a great question, actually. So I think I've looked through the chat, and there are people from all walks of life, from different places, from hospices, etc. So I would like people to take those priorities and potentially maybe present them locally and see what local needs people have, what the interest is in doing some work there. So that, I suppose, would be my what I would like to see, and also apply for research in those areas.
That's good. And while you've just said the apply for research area, I know we also have a question wondering when we might hear about the upcoming grant call around these priorities.
That's a very good point. Usually we open that in May.
Okay, so that's good to look at. Fab. All right, over to you, Bryony, briefly. What would you like to see people do?
Well, I think based on all of the presentations that we've had today, what's going to be really fundamental and something that we would all strive for is that collaboration between people from lots of different disciplines. So I would encourage you to have a look through that long list of 24 priorities. Think about how your own discipline can contribute and where the areas that you may not be in that you might need to look and seek a collaborator or collaborators to work with to address an issue that's important to you.
Fab, thank you. And I think by discipline, you mean not just academic disciplines, but maybe also professional background or your personal experience,
yeah.
depending on where it's at. Wonderful, thanks. How about you, Anne? What would you like to see people do?
So I'm probably really keen to encourage people to have a look at our mental health and wellbeing network and consider joining, and just finding out a little bit more about some of the work that's going on in this area. This isn't work that I'm specifically involved in, but it's just a forum where we're facilitating different people to come and share their research on this area. And then there's also opportunities then for people to get involved in this work, either as participants in research, as people that are on advisory groups, as potentially co-investigators or collaborators. Really important that we have a mix of individuals with lived experience as well as clinicians and academics. So I guess, if you don't mind, I'd just like to encourage people to get involved in that work if you're interested, and that's the way to do it.
Yeah, that's a fabulous call to action, and getting people involved and connected together fits really well with the theme that came across several of the papers around collaboration. And you're giving a way in which they can start doing that, particularly in relation to mental health. Wonderful. And last but not least, over to you, John.
Thanks very much. Well, I think I largely answered that with the last slide there, but yeah. Collaborate with, and well, if you're working as a clinician or you're working in the area and you're not used to working with the social science and humanities, strongly encourage you to engage with people in that space, because they have a lot to contribute in ways that you might not be familiar with. And I think that's the biggest difficulty, I think, with a lot of social science and humanities. It's can feel like a difficult space to get involved with, and at the same time, people often feel like it's something they already know already. So recognizing there's a lot of depth and experience there, and expertise in a lot of the issues that you might be dealing with in the palliative care spaces, that social science and humanities actually have a huge amount of literature and evidence to bring to bear that you can work with. And similarly to social scientists, if you want to any people with a social science background, push that forward, getting involved, get engaged with working with people in this area, because we do need to be thinking, we do need to be applying what we know in this space, because there is a contribution to be made.
Yeah, that's great. So it's recognizing existing expertise, but also mobilizing it in different ways and in different spaces.
I think so.
Thank you. We might have time for one last question here. It is, Sabine, you might be best placed to answer this, or Bryony, about what are the plans for sharing the priorities wider and helping other research bodies and organizations prioritize them? And we have just over a minute left, so a quick response.
It's a great question again. So we had a research summit on Monday, for instance, where we had a few other funders there. We had the NIHR there, for instance. So I think there are certainly some of the large funders will take them forward and look at them, and hopefully some of the smaller charities too.
Yeah, so you've already been really proactive and started putting it under their noses to encourage them to engage with these and think about how they can strategically use them as well. Well, I'm going to say that's it for us for time. So thank you to all of our panelists for their presentations today and also answering quite rapidly the questions we've set to them. I'd also really like to thank all of our audience who's joined us both for the live session, but also if you're catching up on the recording. Just a reminder, do check out the wider conference platform where you can explore other video sessions, the conference posters and the virtual booths, including the one for this session, which is going to have the reports and various links. And yeah, thank you all. And I'm glad you joined us today.